Picture a hospital finance director staring at a spreadsheet. Outpatient revenue projections have plummeted. Last year, a routine colonoscopy brought in $3,500. Now, it's projected at just $1,500. This isn't a mistake. It's the result of a seismic shift in healthcare payment policy. The days of charging more for the same service just because it's in a hospital outpatient department are ending. Hospitals across the country are feeling the shock as site-neutral payment policies take hold. For years, hospitals bought up independent practices, rebranded them as outpatient departments, and billed at higher rates. Same doctor, same office, just a new sign and a bigger bill. This strategy fueled consolidation and massive price disparities for identical procedures. Now, the government is saying, a service is a service, no matter where it's performed. Inflated facility fees for off-campus clinics are being eliminated. This isn't just an accounting tweak, it's a move toward price transparency and fairness. Hospitals must now face a new financial reality. Location no longer justifies a higher price. The spreadsheet on the finance director's desk is a wake-up call. The rules have changed, and so must the business model. The era of easy outpatient profits is over. Site-neutral payment policies mean Medicare pays the same for a service, no matter where it's done. The goal: eliminate the financial incentives that drove up costs for patients and the system. Previously, hospitals could bill more for the same service just by calling it an outpatient department. Site-neutral payments set a single rate for certain services, regardless of location. Facility fees for off-campus clinics are being slashed for a growing list of procedures. The Bipartisan Budget Act of 2015 started this shift. CMS is expanding it. For patients, this means more predictable costs. For hospitals, it's a major challenge. The message is clear: no more paying extra just for the sign on the building. Why is this happening now? Healthcare costs are soaring and Medicare is under pressure to save billions. Advances in technology mean many procedures can be safely done outside hospitals. The old argument for higher hospital payments doesn't hold for routine, low-risk care. Patients are demanding price transparency. They want to know why an MRI costs $2,500 at a hospital, but $600 across the street. Hospital consolidation has reduced competition and driven up prices. Site-neutral payments are a tool to counteract these trends. By removing the incentive for hospitals to buy up practices, policymakers hope to foster competition. The goal: a fairer, more cost-effective healthcare market. The pressure to change has never been greater. For hospitals, the biggest impact is in claims pricing. CMS will no longer pay higher rates just because a service is in an off-campus outpatient department. Payments will default to the lower Medicare physician fee schedule or ambulatory surgical center rates. Facility fees for many procedures will shrink or disappear. Hospitals must update billing systems and stay vigilant. Incorrect claims will be denied or downcoded. Example: a cardiac catheterization that once paid $4,000 may now pay just $900. This is a fundamental revenue shift, not a minor adjustment. Specialties like cardiology, orthopedics, and gastroenterology will feel the impact. Hospitals relying on location-based pricing face major disruption. Accurate billing and understanding the new rules are now essential for survival. Adapting to site-neutral payments is a financial necessity. First, hospitals must audit all off-campus locations and identify which services are affected. Financial modeling is crucial to understand the revenue impact. Next, optimize operations, streamline workflows, manage costs, and ensure precise coding. Some services may need to move to lower-cost settings or be discontinued. Communication is key. Inform staff, physicians, and patients about changes and expectations. Transparency prevents confusion and dissatisfaction. The old growth model, buying practices for higher billing, is dead. Future success depends on clinical integration, quality improvement, and cost reduction. Providers who fail to adapt risk their revenue, compliance, and long-term survival.